Hey, everybody. I am Dr. Josh Elo. I'm joined with Dr. Kirk McCall, and we are excited because a new study came out in JAMA Psychiatry last week looking at LSD for generalized anxiety disorder. Kirk, good to see you. Excited to talk with you a little bit about this new study.
Good to see you as always, Josh, and really excited to sink our teeth into this one.
Yeah. All right. Let's do it. Kirk is working with us doing some as a psychedelic psychotherapist in some of our clinical trials, which is really exciting. And we did some training together, and he's also got a private practice. And then I work at Rush, doing some research with psychedelics as well as have a private practice up here in Skokie. Let's jump into what's going on with this study. Generalized anxiety disorder is kind of an interesting place because there really hasn't been anything that's been FDA approved since 2007. About half of folks don't really get the results that we need. We have medicines, we have therapy, but definitely kind of an unmet need.
Absolutely. It's for me one of the more challenging disorders to treat. I think a lot of that is because people have really great insight into what anxiety feels like for them, what it looks like, and they're very aware of how debilitating it can be in
Mm,
their day-to-day life. I think with other disorders, sometimes it can be a little bit more challenging to outline what the occupational impairment caused by it looks like and feels like. With anxiety, it's very clear, very personal. And as a clinician, can be very challenging to help navigate people through it. So finding new treatments and therapies that might work a little bit better, approach it from a different angle, is always exciting.
yeah, that's a good point. Anxiety is a normal part of life. We all have anxiety before we take a test, or we're worried about a loved one who's not feeling well, or something like that. But generalized anxiety disorder is when it's a little too much, when the ability to control the worrying is very difficult, when it lasts longer than 6 months, when it's affecting several domains of life. And I think, Kirk, in my clinical experience, I feel like the education about this disorder can be validating, right? Like, oh, this isn't just kind of anxiety. This is more, and it can impact people's ability to focus, impact their sleep, impact fatigue, impact a whole bunch. And you can see how all of those are going to have major implications for people's ability to function.
Absolutely. And I think the point you made about it being something that we all experience at one point or another, um, I find in practice when we normalize it in that way, it's very helpful.
Hmm.
Um, and I think even more helpful when folks are like, yeah, I know what that type of anxiety feels like, but this is a little bit different.
Mm.
It's starting to get in the way of things that I really need to do and accomplish. And it's kind of scaled up from just the day-to-day anxieties we all experience.
Yeah. Yeah, when I first heard about this study, I was really excited. I was really interested. I thought, I get it from a depression perspective in terms of using psychedelics, trauma. Okay, I think that kind of makes sense. But this is a very different idea. Greg, what were your thoughts when you first heard about this study?
Yeah, so I remember hearing about it about a year ago when they were kind of just announcing everything. And one, I was very excited that psychedelics are entering the anxiety space.
Yeah.
And anecdotally, we know that psychedelic compounds can be very helpful for anxiety. We know about depression, PTSD, and complex trauma. Anxiety wasn't getting talked a lot about in clinical spaces. And so seeing a study going after that as an indication was really exciting. LSD is an interesting compound to focus on here.
Mm.
We talked about MDMA, psilocybin. Um, the subjective effects that you're experiencing with those compounds are much shorter. With LSD, we're talking about 12 to 16 hours of a trip, which that's a long time. But I think for someone with debilitating anxiety, that's not really responding to treatment as usual, uh, 12 to 16 hours in my mind is worth it if it can
Mm.
lead to durable effects down the road, which we'll talk about a little bit more.
Wonderful segue. Let's get into it. So, in the 60s and 70s, LSD was starting to get some traction in psychiatry. Anecdotally, this is before we really were developing these kind of big RC, randomized control trials like what we're doing now. But some of the early stuff was looking at alcohol use disorder and having some interesting effects. Also, kind of end of life emotional distress, kind of this existential dread. And then, as we all know, LSD was reclassified as a Schedule One drug, and research was essentially halted, went underground completely for decades. Really stalled our progress in being able to understand what these compounds are capable of, or for who, what disorders, like these sorts of things. LSD is a classic hallucinogen. It stimulates 5-HT2A, which is the serotonin receptor that seems to be affected by all psychedelics. So, brain is pretty complicated, but we're pretty sure that that's a big part of this. And LSD binds to it pretty hard, pretty strong. And so it is more, um, the subjective experiences tend to be a little bit more enhanced maybe than some of the other 5-HT2A stimulants. And then generalized anxiety disorder, like I was mentioning, about 50% of folks don't get full remission of their disorder with the selective serotonin reuptake inhibitors. And then we haven't really had any new developments for medications since about 2007. So enter this study, hot off the press. Um, and so this study looked at it was a phase 2B multi-site across the country. It was randomized, double-blind, and placebo-controlled. So, and what was kind of cool about this one is a dose finding study. So people were randomized either to placebo, to 25, 50, 100, or 200 micrograms of LSD, and it was a single dosing session. So it was 198 folks. It was pretty. It was 1 to 1 to 1 to 1 randomization. So it was about 40 that ended up in each of the treatment arms, and they had to have moderate to severe generalized anxiety disorder. So when we talked a little bit before, Kirk, about the struggles with controlling the worrying, some of the cognitive problems that can come along with it, the sleep problems, like these folks hit lots of those different domains. And then, Kirk, I'm curious to hear what you think about this. So, this study, many of these studies are doing the role of the therapist or the session monitor a little bit differently. And this study's a little bit different than what I've seen in some of the other trials.
Yeah, it's interesting that you have the dosing monitors, the dosing session monitors, which is pretty standard protocol for these psychedelic studies. What's interesting about this one is the exclusion of preparation and integration. Uh, Typically, with these studies, you'll have several preparation sessions leading up to the dosing day. And these sessions are designed to give background information and orient people to the dosing day, which happened in this study immediately prior to dosing. What's a bit different with preparation you see in some of the other clinical trials going on right now, there's more of a discussion of the mood disorder that's going on, like depression, for instance, whereas dosing monitors trying to get a more robust understanding of what's been plaguing you and developing a connection with the study participant, um, encouraging them to be curious about different sensations and emotions that are coming up, not just during the dosing session, but during the preparation work we're doing as well. So it can already be in a mindset of curiosity when they're going in. During the dosing day, a lot is coming up emotionally, physically, spiritually, even. And I think it's really important for folks to be attuned to those things that are coming up. That didn't really take place during this study. We are just providing background information, and then you go forward with your dosing.
This was, I think, a piece that I found particularly interesting was, in general, in my work with folks who have anxiety disorders, I would expect more of that prep work to be necessary because, it is a pretty intense subjective experience. And so having, strategies in place, expectations, like kind of knowing how to manage it, I would feel like we'd want to err a little bit on the side of extra, too much prep. But that's not really what happened in this study, and I find that really really interesting. Kind of makes me think a little bit differently about how maybe I'm approaching this sort of work and making some assumptions that may or may not be necessary.
The dosing session monitors are present during dosing days, which I think is important just to provide basic assistance, reassurance. Um, in some ways, that does mirror what we see in the clinical trials, looking at like treatment resistant depression, for instance. It's a very non directive approach. We're really encouraging the study participants to go in and through and really be engaged with the experience without much interference. That part of it does feel somewhat similar, but
Mhm.
I agree. It's interesting that there wasn't more robust um, therapeutic support provided.
This is who came in to this study, and this is a little overwhelming. So let's jump to the demographics piece. So when you're looking at a study like this, you're hoping to find was the randomization effective? Are people mostly the same before we go forward with any of the treatments at the beginning? Are they kind of the same disease? Are they the same like in terms of ethnicity and age? And is this kind of the same population? And you can look here, like there's a little bit of deviation, but in general, from this demographic perspective, people are pretty, it was pretty well randomized. I will say that, you can see in the parentheses in race that in the parentheses, that's a percentage. Like, sadly, many of our clinical trials, there's a very strong majority of white folks who are represented in here. We need to do better with representation in our studies, but sadly very similar to many of the studies that we see recently. And then when we look at demographics at baseline, I think this is interesting. We see here that folks have had anxiety for a long time. The average for each of these arms, is like in the double digits, essentially. Folks who have the Hamilton Anxiety Rating Scale, this is essentially a standardized way to look at the severity of anxiety. They're right around 30, which is, similar to what we were talking about before, Kirk, in terms of that severity. Like these are folks who are having lots of different domains affected. The clinical global impression severity scale, that's a way for clinicians like Kirk and myself who are used to working with people with anxiety to a little bit get a sense of like relative to folks who you work with who has anxiety, how severe is this disorder? And five is a pretty high number. It goes a scale from 1 to 7, and 7 is very, 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 very ill folks. But 5 is pretty moderate to severe. So I think that lines up pretty closely with the level that the Hamilton A showed. They looked also at the MADRS, the Montgomery-Asperger Depression Scale, which is interesting because study isn't looking at depression. But if you look at this, folks were in the 20s in their MADRS. That would suggest that there was some level, probably in that moderate range of depression present on average for these folks. And I think that clinically, Kirk, I think we always see this so often. The comorbidity between depression and anxiety is just so high. And sometimes they just really feed off of each other, or, when one is better, the other one pops up. And so I appreciate that they were looking a little bit there. And there's some secondary analysis that we'll get to in a second. One point here that I wanted to get your sense on is these
Yeah.
folks, they weren't really engaged in psychotherapy through the trial. You can see like a real minority of folks continued in psychotherapy. And so if we're not gonna provide it in the actual clinical trial, are folks getting it on the outside? Maybe there's some kind of surrogate processing or integration that's happening, and not a lot of folks were engaged in therapy.
No, it's interesting and definitely a point that I want to dive into a little bit more later when we talk about the exclusion of therapy here. But we're still having the support, we're still having some of the reassurance provided in the trial. Even if you're not getting it outside of the study, there is an element of support going on. And I think with psychedelic compounds, every little detail matters. And even just a simple amount of support that can still lend itself to robust responses for participants. And I think it is interesting that although you're not seeing a lot of it, maybe there is some element of therapy going on that's hard to quantify.
The last thing I want to say with the kind of baseline assessments here is that many folks, you can see it at the bottom here of medications that were tapered. So everybody was tapered off of their psychotropics before going forward with the dosing, and you can see about half, more than half, kind of were on SSRIs or SNRIs, and then especially this one seemed to be a little bit different relative to the arms, but it got cut off here. The second to the right column is the 200 micrograms. You can see that 35% of folks in that people who were randomized to the highest dose, were on benzodiazepines before they came into the study. So just a little bit interesting to see that. I think that's kind of common prescribing wise for folks to end up on these types of medications, but these were ultimately all tapered off before they went forward with the dosing. All right, so let's jump in. So the first point here that I want to make is that the primary outcome was at 4 weeks for anxiety. So to orient you, you can see that much like the last table we were looking at, these are the different doses that folks were randomized to, with placebo being all the way over there to the right. So we're really looking at difference relative to placebo. And then seeing, because this is a phase 2, it's looking at these different doses. Like, hey, if we're going to go forward with a phase 3 study, what dose do we think we want to do? What seems to be the best in terms of efficacy, but also like managing any side effects that might be coming out? And you can see here that for the 25 and the 50 micrograms, the left two columns, the difference, the least squared mean difference from placebo, that is a nice way for us to just see what was the difference. We don't have to do the calculations ourselves. There was only a couple points difference. But if you jump over to the 100 and the 200, you can see the 100 was 5 points difference and the 200 was 6 points difference, showing that comparing, kind of grouping these apart, there seemed to be more of an effect at 4 weeks in the anxiety for those two arms. Now, if we jump to 8 weeks, okay, good. 4 weeks, it worked. That's wonderful. Life goes on. Does it keep helping? You can see a similar trend here where the 25 and the 50 stayed not that different than the 4. There wasn't anything new coming up, maybe a little bit worse in terms of the number. The 100, a little bit less than it was at 4, but then the 200 stayed pretty close to what it was at 4 weeks, suggesting, oh, there might be something kind of durable here. And then they went forward and looked at other time points as well. So here we're looking at 1 week, what happened to the anxiety score, and now we're going to do a little bit of cheating. We're going to jump to the p-values, because the p-values are a wonderful way for us to tell, like, is this statistically significant? And if it's less than 0.05, that should grab our attention. And here you see that, oh, the 25, actually at 1 week, there was a little something there. That's interesting. But then at 100 and at 200, those numbers are quite a bit below 0.05, suggesting there was something statistically significant at 1 week. Then 2 weeks, oh, same thing for 100 and 200, but we lost it with the 25. Is that placebo response and they actually didn't endure? We can dive into that a little bit more, but we're seeing something happening at 100 and 200 that's not really happening at 25 and 50. And then at 4 weeks, so this one still shows the statistically significant aspect at 100 and 200, not at the other arms. At 8, again, we're getting the separation in the same group. Okay, we're definitely getting a trend here. And then they went out to 12 weeks. 12 weeks. Oh, it's still statistically significant for those arms. So we looked, hey, 4 weeks, that's going to tell us yes or no, this is something worth paying attention to. But the secondary analysis really showed, like, oh, actually, as early as 1 week and through 12 weeks, the 100 and the 200 really did separate. All right, so some other cool data to look at. I mentioned that CGI, that clinician rater scale, hey, I'm working with you, I'm an expert in anxiety, let me see what the difference here. Same thing, not just what the patient's reporting, the people who were working with those patients also were seeing the difference. And these are blinded folks, I should say. They don't know what arm the patients have been randomized to. You see at the 100 and the 200, again, we're below that 0.05 spot, okay? Depression. I mentioned that MADRS. Look again, the same thing. At the 100 and 200, we got a statistically significant improvement in depression scores. And we didn't get that at the 25 and the 50. That was at 1 week. So, okay, what happened at 4 weeks? And again, it endured. That statistically significant difference from placebo at 100 and 200, not just for anxiety, but seemingly also for depression. A couple side effects. I'm seeing more and more as we're getting more of this data, Kirk, that the side effects that come up with psychedelics are almost invariably time limited to the time of dosing and don't seem really to have much in terms of like long lasting side effects. They tend to be pretty quick. And I would say that that's pretty typical with my experience too. Yes, there's many things that happen in the room during dosing sessions, but there many all of them really resolve in a day or two. It's very, very quick relative to many of our other treatments like SSRIs, where side effects tend to have a different time course. Specifically for this one, I would say that this visual perceptual changes is something that really stuck out to me, Kirk. You see even a dose-dependent change in how many people experienced illusions, trails, if you move around, kind of like the outlines of something kind of lagging, actual visual hallucinations. You see it at 46% of the 25, actually 10% of the placebo, which I think is interesting. 46% of the 25, 75 at the 50, 92 at the 100, and then 100% of folks randomized to the 200 had some visual hallucinations. Um, the other piece, real quick, and then we can kind of jump into the fun talking part. Nausea also seemed to have a dose-dependent relationship, and other side effects listed there on the table as well. So, Kirk, where do you want to start?
No, there's so many angles we can take here. I think what's most interesting about this study, and we were talking about it a bit earlier, not just the improvement we're seeing and the secondary measures as well, which is impressive, but the exclusion of therapy, and just saying that and making that blanket statement, there's some nuance that's needed there, that I think they discuss a little bit in the limitation section, but um, with psychedelics, and this is something that we don't focus on as much with treatment as usual. Um, as I was saying earlier, all the little details count. So from the moment the participant arrives to your clinic, they're engaging with a team who is providing support and reassurance. Although you're not doing the preparation work that we're seeing in other studies, you are meeting with somebody who's knowledgeable about the compounds, who's walking you through what you'll experience. And they're spending a long day with you in the room, making sure that you're comfortable, making sure that you feel supported, even though you're not engaging in formalized, manualized psychotherapy. Um, Even just little things like if somebody needs to take a bathroom break during the session, sometimes if you're really deep into it, especially if you're having a higher intensity experience, being able to verbalize that, being able to reach over to the session monitor and say, hey, can we take a quick bathroom break? That can bring up a lot of anxiety,
Mm,
especially somebody who's already experiencing anxiety. Maybe they start ruminating about reaching out and asking for support. This is an important concept to talk about because it's something we discuss a lot in our preparation sessions. What does it feel like to reach out and ask for support?
mm,
What is that like for you in your day-to-day life? For a lot of people with anxiety, just reaching out and asking for that support, tapping into your support networks at home or at work, that's something that people really struggle with. And so in a study like this, where you're not getting maybe the robust discussion surrounding support and preparation, going into a dosing session where you're at the 100 or 200 microgram dose and are very likely experiencing some profound shifts, having that support there and being able to utilize it that can be very profound for you.
I completely agree. And I think this is frustrating and necessary evil, I don't know, of this sort of work is if we really are looking to try to get these available for folks, the two ways, I guess, are sort of decriminalization or states kind of making a decision that's going to change. And then we have like, I don't know, issues related to regulatory stuff or medical oversight. I mean, there's a whole can of worms to put off on. Or we go forward with getting them approved via our infrastructure that's in place, the FDA, getting the DEA to schedule these drugs. And it's been clear that we've learned from MAPS and Lycos with MDMA going forward with PTSD a couple of years ago or last year, that the FDA is not interested in regulating therapy. But in clinical practice, Kirk, I mean, everything that we do when we're prescribing or if we're really doing kind of formalized psychotherapy, like there's always that element at play when we're working with folks and trying to improve outcomes, and I think that there can be a real dissatisfaction with treatment when you're not attending to that level of treatment and just kind of only doing meds, right? And I think
Mhm.
that kind of rings true for some folks who have been through the system before. When you recognize this needs to be more holistic and integrated, not just the medicines and how do we pair it with therapy. I mean, even from a research perspective, we know that medicines work. We know that therapy works. We know that the combination of them is not just additive. Like there's something serotonergic that happens. And so in these trials, when we're really trying to eliminate the therapy component or minimize whatever its effects are and really focus on the drug, I get the desire to do that to play by the rules, but it feels a little incongruent with what we would hope for the standard of care in clinical practice.
Oh, absolutely. And as as a researcher here, I absolutely understand the necessity to try to isolate the effect of the study drug. Makes perfect sense. And I think from an approval standpoint, that's something that you have to show. Practically speaking, and to your point, being able to navigate treatment with somebody every step of the way, provide that support, being able to meet patients where they are,
Mm,
understand what's going on with them, but even more than that, giving them agency and helping them understand what's going on and being able to navigate through that, being able to take insights from your sessions with them and apply those to their day-to-day life. Even if you're not using a psychedelic, we're still doing some of that integration work. It's something that we're trained as clinicians to do. And I think psychedelic work requires that. Um, it's interesting though. And, there's a lot of different conversations happening right now about, the place of therapy here. How important is it? Do you need a clinician or a guide or therapist in the room? Can a container be created by somebody with the exclusion of that therapy?
mm,
Uh, I think it is very possible. And I've seen it happen where people will use a psychedelic on their own. They do their own research. Uh, they feel comfortable going in. The set and setting are appropriate for them. The energy they have going into the session is good. And they're able to make dramatic shifts in their life and really have profound results from that experience. It can be life changing for them. And they don't necessarily need that therapy component, which does speak to the ability of, in this case, LSD to really move things forward. For other individuals, I think it's really important to have a container built around that therapeutic support, especially when we're talking about anxiety disorders. I wonder about the durability if you exclude therapy. And again, this study tried to do that, but you still do have that support. You still do have some follow up. And people aren't left alone here. Um, I think if you were truly trying to isolate the effect of the drug, it'd be very difficult. We would probably not have a RCT, and you'd have to have people at home, and it'd be just field reports of what's going on. A retrospective or perspective type study where we're just looking at what's happening in the field as opposed to really doing a rigorous trial.
I would hate to be on that IRB board.
Yeah, that'd be horrible.
Sorry.
That would be absolutely horrible. Um, but I do think there is something to be said uh, about the value of that support, and uh, for certain individuals, I think it is really helpful to include that. And it makes me think about what happens maybe 5 or 10 years from now when we are able to implement these treatments in practice. I think you're going to have a very nuanced approach. Some
Mhm.
people may be able to come to this medicine themselves and have really dramatic results. Other folks may want a bit more of that support, and they'll seek out a clinician or a guide who's really well versed in the preparation, dosing, and integration work that's required for them. I think it's going to be a wide spectrum, and to say it's going to be just one model in place, I don't know if that's going to be the best approach. I think people find themselves being called to this medicine in different ways, and with that, you have to have different treatment paradigms in place. And the therapy component, especially for folks who are dealing with severe mental illness who feel that this is the path for them, I think that therapy component is going to be critical.
Mhm. Yeah, I'm with you. I mean, ideally, more, it's a little cop out, but I think it's true, more research to maybe be able to identify who would best benefit from
Yeah.
a more comprehensive support structure versus who maybe the autonomy or kind of like the self-guiding might be a little bit more appropriate, but also like obviously with safety being a paramount. So yeah, we're in these early days. We're hoping to jump to clinical applications now because we know there's a need and there's a desire, and people are hungry for this kind of work, and it's exciting. But of course, we ideally will have more information related to safety and kind of who's the appropriate person for these different medications with more coming out and more opportunities, hopefully, for you and I, Kirk, to talk about more studies coming out and maybe be able to inform a little bit about where these um, what kind of model might make sense for individuals. Speaking of, we continue to have some really cool studies going on, both at Rush as well as at Psychiatric Medicine Associates up in Skokie. Here's a couple phone numbers in case you or someone you know who's interested in getting involved in a clinical trial as a participant. Kirk, pleasure as always. It's fun to be in this time and in this space and doing this work with you and your perspective, being in the room, being able to enlighten us all about what's going on. Thanks. It's always fun to talk with you about this stuff.
Likewise, it's great talking with you, and really looking forward to continue doing this work.
All right, till next time.